Thank you all for taking the time to join us today. This webinar is on the power of patient advocacy, and it is hosted by the Heart Valve Disease Policy Task Force. I am Berkeley Barnett, and I serve as Director of Policy and Advocacy for Heart Valve Voice US, and I will serve as your moderator today. We're so glad to have you with us. Today's conversation will explore how patient advocates are shaping policy, increasing awareness, and improving outcomes for those affected by heart valve disease and other cardiovascular conditions. A few quick housekeeping notes before we begin. This webinar is being recorded and will be shared with all registrants after the event. Please use the Q&A feature to submit any questions for our panelists, and we'll save time for audience Q&A towards the end. So we'll start briefly with introductions. I'll have each of our panelists introduce themselves and share a little bit about their organization. Let me pull up some slides. Okay, great. We'll start with Robin, please.
Hi, thank you so much, Berkeley. My name is Robin Peacock, and I am Director of Patient Engagement for Heart Valve Voice US. Heart Valve Voice is a patient advocacy nonprofit organization, and we use our united voice of patients, clinicians, and partners to improve health outcomes for people with heart valve disease and other diseases. We advocate for early detection, strong support, and timely, appropriate treatment by identifying the barriers to care and driving.
Great. Mandy?
Thank you, Berkeley. Hi, everyone. I'm Mandy Sankcooler. I'm the Director of Partnerships and Communications with Mended Hearts, Inc. Just to share a little bit about who we are, we've been around for 74 years now, and we support patients and families who are living with and affected by all types of cardiovascular disease, and that's across the lifespan. So we support children living with congenital heart disease as well as adults. We're active around the world in 38 countries, over 120,000 members, with 200 chapters and groups around the country, working in over 600 hospitals. Our office in the US is based in Georgia, and we have an office in Geneva, Switzerland as well. And our mission is to inspire hope and improve the quality of life of cardiovascular disease patients and their families through ongoing peer-to-peer support, education, and advocacy. Next slide, please. And so that's who we are and what we do. We do a lot. In terms of the support, we offer all types: telephone, video chat, email, all the virtual ways to reach people. We do a lot of in-person support. We have support and education groups that are active in all of those hospitals around the country. We also do online support groups, both for communities and disease specific. We have hospital visiting programs. So we have accredited visitors who go into the hospitals and meet with patients who have just been through a procedure or a surgery and give them the support that they really need. We have discussion communities as well. We give out bravery bags to our CHD families, angel boxes to families who've lost a child, newsletters. We run awareness campaigns, very successful Rock Your Scar every year. We've been doing for 11 years now. Last year we sent out over 55,000 different materials for free to our chapters and groups. We do webinars. We have a magazine that comes out quarterly, health fairs and community programming. And then in the policy space, we have advocacy champions. We have Hill Day. We do a lot of legislative work. So thanks for letting us be here today to share Berkeley.
Thank you for being here. Lisa?
Probably a good idea if I had unmuted myself first. Hi. Sorry, I had to throw some slides together real quick because I forgot these two. So I am the founder and CEO of the Hypertrophic Cardiomyopathy Association. We were founded in 1996. We provide information support and advocacy services to patients living with HCM and thick heart muscle disorders. It is our mission to make the patient journey as painless as possible. and we want to educate our patients, families, medical community, and the public about HCM and all other thick heart muscle disorders while supporting research and development of treatments and diagnostics. Next slide, please. We do that through many services. These are the highlighted programs that we have. So our Big Hearted Warrior Tour, which was supposed to start in person, March of 2020, had to flip to virtual, ended up being a blessing in disguise because we built an entire virtual network of education. We now have, this is a little older, we have over 100,000 interactions on those events. We currently have 56 HCMA recognized centers of excellence with 30 programs in pipeline. I just got back from the Midwest where we've done another review. So there's probably 4 to 6 coming by the end of the year. We have a podcast, Tales from the Heart, which talks to KOLs, industry, patients, all different types of stakeholders in the space to hear their real lived journeys and to keep up on the latest science. We have a medical education program we're partnered on, which is called HCM Academy, which is free CME courses to anybody worldwide. We have hit over almost 200,000 engagements on this project so far, and it continues to grow. We do a peer-to-peer navigation and intake and navigation system. We take over 1,000 calls a year. We deal with everybody worldwide, regardless of access to care issues. We are here for them to help them assess what is available in their region of the world. We are currently working with partner organizations in 9 other countries to develop advocacy voices in those countries. That's under our programming called HCMA International. And stay tuned for more from that. We run discussion groups, which are populated and run by trained moderators. And we have 14 to 16 groups a month now in that project. There's a whole bunch of other services we have, and you can learn more about it at 4hcm.org. And I come not only as a patient and a parent and a family member of somebody with HCM, I'm also a heart transplant recipient. So that explains who we are and what we do. Thank you.
Thank you. So to begin, let's discuss the impact of patient advocacy. Lisa, I know you came prepared with a couple of slides to share your story, or share a patient story. Could you please tell us a story and share how it has impacted policy or perception?
Okay, so this is a picture from our last Hill Day, and we told this story on the Hill because one of our actionable items is the inclusion of family heart health history in the well child examination to ensure that the physician knows what's happening in that family and what risks they should be looking out for. So I'm going to tell the story of Jillian. Can I see the next slide, please? There are some animations here. So we're going to be looking at this family perspective from the mom's point of view. So as I'm giving relationships, so let's pause there for 1 second, please. So the first person that pops up is a nephew. He has open heart surgery back in 2005. It's HCM, but the family isn't really thinking that this has anything to do with anybody else because they were told he was fixed with his myectomy. Not true. HCM is a lifelong condition. In 2015, brother has a valve problem, goes for surgery in a small hospital in Iowa, and dies on the table. And then they diagnose him with HCM postoperatively. The sister ends up with atrial fibrillation in 2017. Now, at this point, the mother of the child we're going to be talking about has not seen anything in this family history as impacting her or her children, but they did ask. And they were told by community cardiologists in the 2015 time range that HCM only affects males. I'm here to tell you that is not true. HCM affects anybody regardless of gender, ethnicity, age, or location on the planet. So this family had this history. Mommy is a nurse. She knew this history, but she listened to a physician who told her it wasn't her problem. It was a male's problem. Next slide, please, or next connection. Just enter one more. There you go. So that's mom. So go ahead, one more. And mom has 3 children. The youngest of which, next slide, please, or next connection. The brother's family gets genetic testing after he passes away from the nephew. That should say nephew, not brother. And they find a gene. So they know that there's a gene, but they don't know that it matters to them at this point. Next slide. In June of 2021, Jillian goes for a well child exam. Nothing weird detected, no family history discussed. In February of 22, she gets to her well child examination and a murmur is detected. And it is not a slight murmur, it is harsh. And that triggers them to go for an echocardiogram. Next slide. Takes about a month to get that appointment set up. We get an echo, an MRI, and an EKG. And the team wants to do genetic testing because this is a very, very thick heart. Her wall measurements are in excess of 3 millimeters, which is a high risk phenotype. But now it's so thick and she's so young, they're wondering, is it a phenocopy and should that be treated differently? So they wanted to get the genetic information. And they did. Next connection. So they get the genetic test results on April 21st, 2022. She has the same marker. She has a gradient of over 150. She has a wall measurement of over 3.0 on both MRI and echo. And we have determined we are high risk and we are going to go off for a defibrillator. But we don't get there because on that very day, she climbs the stairs and has a cardiac arrest and is unable to be resuscitated at the age of 17. There was just not enough time to get her to her therapy, but there was so much time wasted in advance with misinformation. Next slide, please. These are real people. They aren't just avatars. These are the people, this is the family that we are speaking of. And Jillian isn't with us any longer. But what we have done with her story through her mother, Amy, who is now a staff member here at HCMA as well as a nurse navigator, but Amy had the bravery to come to Capitol Hill with us. Amy had the bravery to sit in every one of our legislative briefings through Heart Month and tell state legislators that this timeline didn't work for her daughter because we didn't have enough time to get her to therapy. But had we had known years earlier that she needed the cardiac imaging because of this family history, we wouldn't have been able to get that defibrillator in on time, and that day may have ended very differently. Next slide, please. If we go to an actual slide now. Oh, an update. Mom is now listed for a heart transplant. So this family didn't end with a child dying and a bad end of story. We did find other people in the family who ended up needing care and didn't know it, including mom. Next slide. So this is a legislative initiative that we're moving forward at a state level. We want every well child examination to include the same things that we're looking for in student athletes: family heart history, symptoms, signs of cardiac disease. And we have passed this law now in New Jersey, Virginia, and Nevada. Now, each state has slightly different iteration of the law, and we're moving on with other states that we have bill numbers on that we're moving hopefully in the fall. We want to improve professional development on the those who are providing those screenings. We want to make sure that every student athlete pre-participation physical includes family histories of heart disease and that there's some education involved in that as well. And we want to improve the ability of healthcare providers throughout the community to identify those who have disorders that can be treated. And of course, we want better AED CPR training in all communities. But Jillian's story feeds into that beautifully, in that had we gotten there just a little bit earlier, she might still be with us. I prefer to choose heroes that are with us to tell their story, but sometimes it's those who have passed who can tell the most meaningful story and get a legislator to really listen. And when you show the pedigree of the individuals as avatars, it doesn't bring it home to them. So we always kind of tell the story and then we tell them who the real people are. Jillian was a quirky, bohemian, chic, alt kind of thinking girl who wanted to be a designer. She loved David Bowie. She loved that avant-garde kind of look, and she's not going to get a chance to play that out because she lost her life at 17 to the inaction of the healthcare community recognizing the importance of family heart health history. And I think I will end there, but just one more slide just to thank my entire team who helps make all this good to happen. Oh, they didn't give me my thank you slide. Okay, never mind. Thanks to my team for everything that they do to help us look connected when we get out here.
Well, thank you so much, Lisa, for sharing that story. It's truly impactful and shows how, you know, patients' stories really can influence policy. Mandy, could you talk a little bit about how patient voices have driven real change through Mended Hearts?
Yeah, I'd be happy to. And a little bit later, I'll talk about some of the work we've done in the valve disease space, but wanted to talk about an example that's pretty fresh in our minds because it happened this past July 4th with the Orphans Cures Act, when it was successfully included in the passage of the big bill. We're a member of the Rare Disease Task Force, and members of that task force worked really hard throughout the entire approval process of both the House and the Senate, with meetings and continual onslaught of letters to important policymakers to try to make sure people understood how important this act was, that it was included. And basically, the Orphans Cures Act allows drugs that have more than one orphan designation to be immune from the Medicare drug price negotiation program. So an orphan designation is really a special status that's granted to drugs being developed to treat rare diseases. Although they affect a small number of people relative to the overall population, only about 5% of people who have a rare disease actually have an FDA approved treatment option, which is incredibly low. And it leaves almost 30 million people in this country without a treatment. And so the fact that this Orphans Cures Act has now been included in the bill means two things. It means that people who are living with a rare disease have increased access, because if there's an FDA approved treatment for one rare disease and it's found that it can be used to treat a different rare disease, or two more or three more, those additional indications don't have to go through the CMS approval process. So it could mean the difference of someone getting the treatment and living, or a few months later, finally it being passed and we've already lost them. So it's a huge win. And it also encourages pharmaceutical companies and to continue investing in research and development, because it's incredibly expensive, as I think most people on the call know, to bring a drug to fruition. And if it's a rare disease, there are going to be fewer people buying it. And so in order for them to see some return on what they've invested, if it's approved for more than one indication, the companies are more likely to invest in that disease area. So that's a fresh example of how advocacy groups pulling together can really make a difference to save lives.
Thank you. Robin, could you talk a little bit about what makes advocates uniquely powerful?
Sure. Wow, listening to your stories, Lisa and Mandy, that's just incredible. So I also am a patient. I'm an open heart surgery in 2022. So I speak as a patient voice, but also now as a patient advocate. And as patient advocates, we use our voice to represent all the patients that either aren't able to speak or are not part of this healthcare world that I'm now a part of. We share our stories to drive change. And when we go to Capitol Hill, we share our stories, we share our lived experiences with the legislators for them to understand what our quality of life is, how our disease is impacting us. And it's super important for people to understand that patients aren't just our voice. We should be partners. And so one of the drives that I'm out there doing right now is really trying to elevate the patient voice to a partnership level in research, in meeting with clinicians as, speakers on panels, those types of things. So as advocates, we like to educate, and we like to educate doctors. We like to educate the nurses, the staff. We also like to educate families. And, Lisa, to your point, I think it's a super idea, because one of the things we are all out there advocating for right now is early detection for cardiovascular disease, especially heart valve disease. There is no test. I mean, there is a test. We could all get echoes, and we could easily start with the cheaper stethoscope. So I love the idea of trying to get this family history really knocked out during well child events. I was born with a congenital heart defect. I was adopted, so it added that to it. So I didn't know my heart history at the time. So as advocates also, a lot of organizations such as Heart Valve Voice, we have an ambassador program, and we're training ambassadors to go out and be advocates for those with heart valve disease, either, working with their local social media or their local media, also posting on social media, attending conferences, writing blogs, just, any way we can bring awareness to the risks, the symptoms of valve disease. One of the big issues right now is the asymptomatic patient who shows up at the last minute and all of a sudden they have had 0 symptoms and they now are looking at possibly an emergency treatment because they presented for something else. They had a head, they had their lungs hurt, they went to the ER, they listened, and all of a sudden their severe aortic stenosis was diagnosed. So we're really working on how to help the asymptomatic patient as well. What's the goal of patient advocates? Our goal is to make the experience living with this condition better. We want your lived experience to be better, but we also want the clinicians, we want their experience to be better with us. We want them to understand how we want to be spoken to, how we want to learn the information, how we want to receive the diagnosis. What type of processing time do we need? Those types of things. What are our treatment options? What are other options that might not be the quote gold standard? We want clinicians to understand that we are a partner in this process, and we want patients to understand they are a partner in this process, and to continue to ask the questions, go to your appointments prepared, go for second opinions. I know as a female, it's hard sometimes to disappoint people and you want to be agreeable, but this is not the time for that. And we are out there all the time saying, ask the questions, don't be afraid. If you're afraid to hurt your doctor's feelings, then you probably might need to go look for another doctor, one that you have a better connection with. Easier said than done. I appreciate that. So part of the education that we help patients with is how to have those difficult conversations with your staff, with your treatment team. A big piece of patient advocacy that we really are trying to support is getting patients into research. And research studies, I think that as a participating patient, there's a lot of fear. There's a lot of fear involved. What is the study about? Is my information going to be released? How are my privacy concerns addressed? Am I going to be taking a placebo? Am I going to get the real drug? It's all that. So as advocates, we are learning how to have those conversations with the general population. I mean, every disease needs people in their research studies. It's not just heart disease. I do think that as a patient panel advisor, that's another option for patients. They aren't part of the research study itself, but they actually help design the research study. So one of the things we at Heart Valve Voice are out there doing is trying to engage with those institutions that are having research studies, and we're trying to get in early in the study so we can help design, even down to a situation of the right photograph. How are you representing my community? So and at Heart Valve Voice, obviously, our patient advocates jump on our My Valve, My Voice calls. We have a monthly support call, and we are advocating for the newly diagnosed patients and those that are still living and still want some support. So I hope that helps you, helps answer your question, Berkeley. It's a lot.
Yes, thank you. So we all know that one of the keys to successful advocacy is collaboration. Lisa, could you share a little bit about how all of these organizations work together to amplify advocacy?
So many of us are part of Global Heart Hub, Cardiomyopathy Council, and we collaborate through that more structured means. We have some ad hoc partnerships that we are working on through like our relationship with Patch, and we can all collectively work together through those efforts, which has been great. We have worked with a number of different organizations over the years, either on collaborative meetings or coming up at the end of September, our friends at the SADS Foundation wanted to participate in HSFA. We had a larger booth. We're splitting our booth at HSFA so that they can get an experience there, and we help elevate their voice there. So sometimes it's the little stuff. Sometimes it's more structured programmatic approaches. We have a project that is out now called the All Hearts Collaborative, and this is a project that is based as our pilot in Newark, New Jersey, and we're working with all of the community level organizations that have school and education and healthcare outreach to bring our message into them. And we have found some great partners outside of the partners in the cardiovascular space, but in the general healthcare space. We do nothing alone. We steal lots of ideas from each other and customize it for our own good. And I offer anything that we've created to be repurposed for anybody else. And we're happy to talk to you about that. And on a global level, HCMA is working with advocates, industry, and KOLs in multiple other countries to help develop their advocacy voice in other countries, specifically Sweden, Portugal, Mexico, Brazil, and Australia. So as we all find these ways to build projects together, sometimes it's informal and sometimes it's going in for grant funding together on larger projects. So we've been working with Women Hard on projects. We've been working with, I said, SADS on projects. We've been working with the community programs and this global approach through Global Heart Hub. So we don't go alone. Oh, and we've been working with American Heart on a number of issues as well. So we're not going out anything alone. You want to make sure we're all partnered on a concept. We're all trying to do the same thing. We're all trying to find people with a particular disease to help them get to the care that they need to get to and feel supported all the while. We each have different ways of doing it. And I think that partnership is the only true way to address the larger problems because nobody can do this work alone.
Mandy, could you share a successful coalition or partnership effort?
Yeah, sure will. And actually it has to do with this group here, and that's the Heart Valve Policy Task Force. And so kind of following up on what Lisa said, we can't do anything alone, especially when you're a group like ours that is there to serve all types of heart conditions. So it's almost impossible to understand what is going on in the policy space for heart attack, for heart failure, for heart valve, for cardiomyopathies. And so we really rely on those partnerships, like the one I talked about before, the Rare Disease Task Force, or like this one, the Heart Valve Policy Task Force. And so some of the work that you've been leading and your team has been leading is the work around the TTVR, and that's the transcatheter tricuspid valve replacement, that you guys led efforts, letter writing efforts to CMS, and getting so that they knew how important that that coverage was for patients. And Mended Hearts signed on to some of those letters. We actually wrote our own letter as well. So it was a nice example of how you can inform us of what's going on and give us opportunities to participate. And then we can also reach out on our own and really amplify those efforts. And you let us all know back in March that it was successful and that now treatment is available and will be covered for people who have symptomatic tricuspid regurgitation. So kudos to the task force and to all the groups that worked hard to get it passed.
Thank you. Yeah, it's one of our big initiatives is making sure, of course, patients have access to care, and where many voices is much stronger than one voice. So we're grateful to have collaborators on all of those efforts. So now let's talk about barriers. Mandy, what barriers do patients face that policies can address?
So what the barriers for me and for us always come down to access. So what does that access look like? A lot of times that access looks like step therapy issues, and it looks like cost issues. So if you asked a number of our members what is their biggest issue with medication, it would be that they're being forced through their insurance companies to go through step therapy. And what that means is that their doctor knows a treatment that's going to work for them. You see it a lot in the cholesterol space, but it's in many different areas. But their insurance company says, nope, that option's too expensive. So we're going to make you try A, B, and C before we get to D, which we know is going to work. It's an infuriating issue, And it's one that patients do understand well. I think an issue that patients maybe don't understand as well because they can't see it, it's not as transparent, are the issues around the 340B issues, like payment coverage and pharmacies and hospitals and how they all work together, and the prescription drug affordability boards that are happening in certain states. And it's basically, these programs have been set up to try to improve access, and on, from the outside, it looks like they're helping. They're helping patients afford medications, they're helping access to medications, but they are not transparent programs. And because of that, in the case of 340B, with this program that all pharmaceutical companies pretty much participate in, big hospital systems have kind of taken it and used it to make money rather than to give back to the patients. And we don't want to see the program go away, but we want to see it be more transparent. And with the prescription drug affordability boards, those are supposed to help with the cost of medications. But if this board decides this medication is too expensive, pharmacies won't be able to hold those medications, and then patients won't be able to access those medications, especially in rural areas and underserved areas. So cost and getting the medication you need without going through the insurance rigmarole are two really big issues for our members.
Thank you. Lisa and Robin, where are some of the bigger gaps in care, and how are your organizations addressing them? Lisa, if you want to go ahead.
So I'll jump first and then Robin, thanks. Well, I've been at this for 30 years. And before the ACA, we had about 17% of our population that was uninsured. And then after ACA, Medicaid expansion, et cetera, we were down to like 6%. And that number, I'm fearing, is going to grow again as we have changes to the subsidies on ACA plans, making it unaffordable for families, and the questionable future for Medicaid for our adult members. I kind of feel like we're going to be okay with the kids because I think they're going to fix something there. But I'm afraid of our adult patients who are on Medicaid. They're suffering. They've got heart failure symptoms. They're not bad enough to get to transplant, but they're not well enough to work. So this is going to be a major issue for us going forward. And I hate the 6% uninsured that we currently have, but that's not going to get any better in the next short future. So we have to make sure that we are creating safety nets to ensure that patients who are diagnosed or have defibrillators or need surgery have access to those resources as best we can. We're advocacy and nonprofit organizations. We're not magicians or politicians. So we can only create safety nets where we see the need. We provide travel stipends for patients to get to Center of Excellence care because it is difficult for everybody to get there. So whatever we can do to Band-Aid that together, we're going to have to do. And then to piggyback on what Mandy said with the expensive medications, HCM is in a space now. We finally have branded drugs. We finally have labeled indication, and it becoming more and more a game to get patients to be able to get on them. And we need that because their alternative is open heart surgery. And some of us have been there. And if you don't have to go, don't go. But if you need to go, it's okay. But let's try to avoid unnecessary surgeries because they come with unintended consequences sometimes. So if we can treat people with medications that remove that risk of surgery, that might be optimal for some people. Some people may still need to go on to surgery. But in our case, there are only a handful of doctors who know how to do this very artful myectomy. Patients need to be able to get to the people who know how to do it the best, rather than accepting the person who kind of knows and maybe won't kill you, but you're not going to get the optimal outcome. So we continue to battle insurance appeals with our clients to make sure that they get to what they need, and we win about 95% of the time. So we've got it down, but we continue to ensure that patients get the care that they and their doctor determine is appropriate, not their payer system. Robin, your turn.
Well, Mandy and Lisa, you guys are so well versed in the whole policy aspect of this arena. I'm going to take it to the grassroots. I'm going to take it right to the patient. right? So you talk about access, you talk about location, the cardiac deserts that we have in the United States and around the world, actually. The biggest gap is one, getting at the base level, educating the patient on what's out there, right? And because a lot of times the physicians and the clinicians are not able to give the best treatment, like we talked about with step therapy, because of payment, right? Well, a lot of times, most of the time, in my experience in talking with people, patients, they don't know there's drugs past drug A. And they don't know that when you hurt a body part and you need an MRI to figure out which ligaments and which tendons are done, you're sent off to physical therapy. And so patients don't have the education to know, to advocate for themselves, to skip A, B, and C to get straight to D, right? So how do we do that? To me, that's the grassroots issue, is educating the patient on what their options are. You say that there's only a few people, a few physicians, a few surgeons in America for the myectomy. Well, I didn't know that. And I would love to know more, because we need to educate people that have the condition that needs that, right? And so again, it's grassroots. It's back to educating the patient and supporting the patient at the patient level, and their caregivers and their home support team. You've got the gaps in the socioeconomic status, right? And so your organization, Lisa, provides travel vouchers. Well, not everybody is going to qualify for a travel voucher from you or the many other organizations that provide that. And so how do you get someone to a main medical clinic? How do you pay for their gas, their child care, the food for the babysitter, because you've got to be gone for 3 days. I mean, there's extra mouths to feed when, and then you've got to feed yourself on the road and your care partner. I mean, the list is endless. It extrapolates upon itself. So I'm into the grassroots level, and I am so appreciative that you guys are at the policy level. I'm fascinated by it.
Robin, you created a great transition point for us as well. And let's discuss how to empower patients and caregivers to get more involved in their care journeys and some access issues. So, Mandy, how can patients and caregivers get more involved?
Oh, this is so tough. And Robin, I just want to bend your ear a little bit, because you are that grassroots advocate that we're always trying to engage, because it's tough. We try as an organization. I know so many other organizations like Lisa's and yours. We work to provide the training and the opportunity and the need, but there's time. Like in all patients, advocates, families are limited by time, and that can be tough. And so we've had a couple, Berkeley, I was sharing with you a couple of opportunities recently. One was with the FDA, and one was with a PDAB, which I talked about before, for patients to share their stories. It was really hard to get patients to do that. And I think part of it comes from properly communicating what the need is. And so going at it from a few different ways of communicating that need and making sure that patients understand how much their story is valued. But also there can sometimes be a disconnect, especially like with those cost issues. When it comes to things like, some of the things Lisa's been talking about and Robin, you've been talking about, it's very easy to understand why you have these life-saving devices, right? Why that's so important. What's not as easy to understand is how hospitals and pharmacies are misusing some of the money that should be passed along to patients. And so with those opportunities, it's tough to convey that to patients. And I hate the word patients, people living with different conditions, but patients is just easier to say sometimes. But it's hard to convey the urgency and the need for their voice in those conversations. So that's where the need for clear communication, a need for storytelling to illustrate, look, this is what could happen if you don't make sure your voice is included. So just clear communication, understanding it's not always easy.
Yes, Mandy, It's hard. It's very hard. I think that I know with Heart Valve Voice and with other organizations, there's a big push for reaching out to the people, the patient communities, because literally everybody in the world is a patient, right? We're just talking about the heart disease world right here, but everybody's a patient. Even the doctors we're trying to get to learn to understand how to speak with us, they're patients. So I think that a lot of organizations are focusing on the patient voice, the patient story, and trying to elevate the need for that. And I know for us, we've started with the Patient Ambassador Program and with our My Valve, My Voice platform, we are reaching out, looking for people who want to share their story. And one of the things we have to be aware of is some people want to share their story privately, anonymously. Some people want to share their story in public on a stage. They're comfortable in a speaking role. Some people want to be on webinars, seminars, patients on panels. So you have to really come to the patient and see where their toolkit is, where their comfort zone is. How do we get those people to participate? I think, again, this is a great, excellent way for us to collaborate together. We are all collecting patient stories, right? There's a patient story registry in probably every one of our organizations in terms of whether it's just in your mind or your staff's mind. Oh, that was a patient I spoke to last week. That would be applicable to something Berkeley's working on over at Heart Valve Voice, right? It's the collaborative effort. But then how do we get people who are not really part of our immediate communities? How do we get out there? We're all on social media. We are all doing, paying marketing teams to get out there and look for people. Just this past week alone, there's been a couple of different ones on LinkedIn, share your story. We're interested. And I love seeing it out there. My goal is to start copying those links, creating a master list so I can share it with our community, right? The Heart Valve Voice community, because you never know also when a patient is in the right space to share their story. And just because my surgery was 3 years ago doesn't mean my story's over. And as I get further away from that event, my story has evolved. And I have not had complications, but I know plenty of people who now have other complications. Their story and their heart journey of treatment and access has continued. So you've got to catch the patient at the right time. So a lot of people may sign up. I would love to share my story. Here I am. And then by the time you get to them, maybe something's happened in their daily life. They're not able to commit the time to it. It's also scary for people who aren't used to sharing their story. I don't know if I've really answered your question, Mandy, other than I think we all need to collaborate together and share the stories, but we also have consent. We also have to make sure we have consent from every one of these people that are sharing their stories with us. And I know we're all very careful when we are talking with one another to not use identifying names, identifying factors, but we're talking in the general sense. Well, I was just speaking with a heart patient who is going for surgery next week, and these are her concerns or whatever, right? So I think that there's space in our groups, in our world, to share, to collaborate, and not recreate the wheel when we're out there. And I know there's aren't there? I mean, I think there are, right, Berkeley? There's registries out there where you can sign up and you're supposed to get emails when an opportunity comes up with your disease or what you checked. I've registered with probably a couple of them. I've never received an email. And granted, I don't have crazy diseases, but I did have endocarditis, which is super important for all of us to educate people on, right? And
Been there, done that. Don't want to do it again.
Don't want to do it again. Open heart surgery. I mean, but I'm adopted. I mean, there should be a whole program of adopted people who have congenital diseases, right? Well, the American Congenital Heart Association. They're fantastic. You know, they're working in the congenital heart space. But where are the emails to me and all the other congenital patients? Hi, we've got these research studies, right? Same with us. I mean, so I think we all need to work together. I think this is a great way for us to create conversation.
I think
So
Robin
we're-
too. Oh, go ahead, Lisa.
Yeah, no, go ahead.
I was going to jump in with 2 observations. Number one, we've held a patient-focused drug development meeting, and we're actually going to be doing another one next year, specifically to genetic disorders that cause HCM phenotype. So we've done the public-facing patient voice story, and I see somebody that helped us on that project is here. Hi, Gwen. So we've done that storytelling that is public, that is in the public domain now as part of our PFDD, and we'll do that again. We have our Share Your Stories. We have our social media communities where people talk together, but I'm going to give you a cautionary tale. And it just happened to me this summer, and it's heartbreaking. It's some people who share their story, maybe sharing their story because it became a hero story. They had a thing done, they got better, yay. But patients don't always stay better. And sometimes they go into forms of depression when they have shared their story again, but they're not really feeling well anymore, but they feel obligated to feel good. So they tell the story that they're still feeling good. And in some cases, this can lead to all kinds of downstream consequences that we didn't expect when we were telling their story. So as we tell their stories and they're on our websites, we should be checking in with these people periodically. Are you still good with sharing your story? Has it updated? Would you like to add to it? Because we know you add. So we've gotten into the habit of every year in Heart Month, the people that we share throughout Heart Month, we do updates when we can. Here's what's going on in their life now. This other individual was not part of that particular program, but was being worked with by a hospital because of the procedure that was given to them. And he stopped doing well. And he went into depression. And then we're dealing with addiction to mask the feeling bad about giving somebody information on a procedure that was helpful to them, but now is not. So I just send out the message that these are real people with real lives and they evolve. And things may change. So when you're sharing a story, please be careful that you're focusing on the mental wellness of that patient and doing check-ins on a regular basis. So I love sharing family stories. I love sharing patient stories. Mine has been out there for a long time, but there have been times in my experience where I didn't really want to talk about me as the patient. I want to do the work. I don't want to talk about being the patient who was diagnosed at 12 and had a stroke at 21 and endocarditis and and 5 defibrillators and a leadless pacemaker in my transplanted heart and all this chaos. Sometimes you just want to do the work and not tell the story. And sometimes you want to tell somebody else's story, and sometimes you need to tell your story. So as you're out there, the stories and the real lives and the real people matter, which is why when I did my pedigree, I then put the pictures in, the real people. But that story is still evolving. It's not static. Even though a child has died, the family moves on. And then other things happen related to the disease, like somebody needs a transplant. So they're important stories. Industry needs to hear them when they're building clinical trials. Oh, the other piece that I wanted to give a shout out for back on clinical trials, because we get nowhere without clinical trials. You all do realize that I would not be here if not for clinical trials. I would be dead now, and many others would be too. So God bless clinical trials. We put out a call to action. I had a room of 700 biotech professionals in New Jersey for like 3 minutes. So what am I going to do? I'm an advocate. I ask for things. So what did I ask for? Let's have these companies practice what they preach and give individuals days off for clinical trial participation, whether they want to call it under their volunteer policy, community service policy, paid day off. And now there's been 11 companies, I believe, in the state of New Jersey that have enacted clinical trial days off as company policies. So sometimes it's not about finding the patient for the trial, it's getting them the access through something that they didn't even know was available to them. So you got to be creative. I come from an HR background, so I tend to think about employment things from a different way. But that silly little idea got taken over by BioNJ, who made it part of their little mission. And now Mass Bio is looking at it as well. And things grow. So tell the stories, but ask for something when you're telling the stories. And sometimes it'll come through.
That's amazing, Lisa. I love that that's become an initiative. One important question that I really want to talk about is how, Lisa's specifically with HCMA, how do you reach and engage patients whose voices have historically been underrepresented?
So we make sure when we are doing any kind of recruitment that we are sensitive to the fact that in America, the story of cardiovascular disease has predominantly been told by white people. So we try to get people of color to share their stories and to speak to members of their community. Our Project All Hearts Collaborative is going into communities of color. So the Newark, New Jersey is Portuguese and Black, as it 88%, I believe, is the number. So we're working with that city to try to find the ways. We don't know. We haven't done it before. So we went to the community and we had a lot of listening sessions. And we talked to community leaders. We talked to patients living in the community about how they get access to care. We're talking to the people who live there, and we're finding out how to communicate with them better. And we found out some really interesting things. Like they don't want digital, they don't want YouTube, they don't want Zoom meetings, they want paper. They want something to go home and read on their own. So we've started to create more materials for that community, and then we'll see how they work in other communities as well. So I think listening more than you talk sometimes is critical. And that's what we've been doing to hear the voice of the underrepresented patient.
Amazing. Thank you. I think that we have time to answer a couple of questions from the audience. If you have any questions, want to put them in the Q&A, please go ahead. But one question is, how do you keep patients motivated and engaged in advocacy over the long term, especially when policy change can take years?
I'll
Who wants?
stab at this one. I'm going to speak from the advocacy, the patient panels on research studies, because, the first year of of participating on it as a patient advisor is super exciting. And then the second year, the third year, it's not as exciting because you're not involved every week or every month. And so one of the things that we are doing with our patient ambassador program is we are trying to set up a schedule of monthly calls, monthly check-ins. I want to keep the enthusiasm going. And the same with the patient panel that I assist with on one of the studies. I'm trying to keep them engaged, educate. It's communication. It all goes back to communication. They matter, right? Those ambassadors have committed to Heart Valve Voice to help us help others. And so we need to make sure that we pay close attention and show them respect for their time that they are devoting to us and to others. And the same with the research patient panels. So that, I think you've got to keep engaging and show respect.
I would double down on that. It's about the continuity. Messaging sometimes feels redundant from the inside because you're talking to different audiences at different times. So keep talking, getting those points together, and keep encouraging people to come back. It's not launched yet, so don't judge me because you can't go look at it right now. But we found that people want to give us time, and we have almost 1,000 people signed up to be volunteers, but I don't have enough jobs to give 1,000 volunteers. So what we've started to do is to create micro volunteer moments so that you don't have to spend a lot of time. You can do something in 8 to 10 minutes. We're calling them 15 minutes, but they're really only 8 to 10 minutes long. And it's send letters here, advocate, use your voice, tell your story. We have our ambassadors, we have our committee members, we have our volunteers on different projects, but it's constantly communicating, thanking our participants for being there for us, valuing their time and their story, coming prepared to the table to be able to produce and give them something to do that makes them not only feel like they're doing something important, but to validate their purpose in life. It's beyond just going out and telling what happened to you. It's not what happens to you when you have HCM, it's your life. And it's how you're leading your life with this difference, and sharing that and encouraging people to do things on behalf of themselves and others is critically important. And thanking them for their contributions. We do it at least publicly annually, but every time we get to talk to one of our volunteers or somebody who's sharing their story, is telling them how absolutely important and integral they are to the process.
If I could just add, I think it's important too that there are other places. I think, Robin, you're talking about the grassroots advocacy. So when you give a lot of opportunities for people to share their story and be an advocate at both a grassroots level as shared decision making and making sure that they understand that that is just as powerful as being in DC talking to a legislative office. So there are lots of opportunities within Mended Hearts and other organizations to, be at the bedside of a patient, advocating for that patient, to have a conversation with their doctor, to be with the family and advocate for the family to have a voice in the decision-making process. Those advocacy opportunities are just as important as the policy opportunities that come up through all of our orgs.
What advice would y'all give to industry to be good partners?
Talk to us early, talk to us early, talk to us early. Did I mention talk to us early? There's nothing worse than having them come in a little bit too late and having made a big misstep or having to redo work that they've already done. I started working with a little company called Myocardia back in 2012, and they said, we know nothing about this patient experience. And we started to build that with them in 2013, 14. We got to a label in 22 with a startup company. That was less than 10 years from concept to label. Now, BMS bought them in the interim, and that's where they landed. But we were there every step of the way for that development, and it was super exciting. We recruited the patients for the phase 1s, for the phase 2s, for the phase 3s, and we were partners in watching the first labeled indication drug be presented for HCM. And that's exciting for the community. The patients that were part of it were thanked and were represented, and we really appreciate them, and telling them that regularly is important. And now that the drug is made to market, the patients who did the early work are being thanked by the patients who are just going on therapy now. And it's amazing to watch that cycle come around. It's the first time I got to see it from start to finish. And now we have other drugs in that pipeline and other concepts and new targets. And it's super exciting. And we're talking to no fewer than probably like 9 or 12 different organizations on different things right now. And they're not even in phase 1s in some cases. They're just at the desk going, we think this might work. Here's our theory. We want to talk to you then, because we can help plug you into the rest of the network of everything. Because I live all things HCM. I don't know why y'all don't do that too, but that's what I live all day. So we can connect these early development people to new concepts and new ideas that are already existing someplace else. I have a nickname. It's called the connector. I'm like, hey, did you know that guy over there is doing this thing that's very similar to this, not competitive, complementary. Y'all need to know each other. We have the capacity of doing that too for industry. Who else?
Thank you, Lisa. Well, we are at about time, but before we wrap, rapid fire from each of y'all. What is one key takeaway that you hope people in the audience remember from today?
Partnership. It's incredibly important.
Hashtag listen to your heart.
I was going to say partnership and partnership. We can't, nobody here, especially in 2025, can do anything alone. This is all hands on deck. We may have different ways of getting to the finish line, and that's great because one way doesn't always work. So be open-minded, look for partnerships, and let's try to remember that we're all in this together.
Yep.
Couldn't have said it better. Well, thank you all for joining today, and thank you to our speakers. We will share a recording and any resources that you may need following this webinar. So please feel free to reach out to any of us or any of our organizations, and we're excited to get connected and keep moving the ball forward. So thank you all for joining today, and have a great rest of your weeks.
Thank you.
Thanks, Berkeley. Thanks,
Perfect.
everybody.